it is in your part of the world. As you just heard, we will be recording this session so that it's available for everybody who was interested but unable to join. If you are not comfortable with the recording, you can switch off your cameras. If you're comfortable, we would love to see you if your bandwidth allows for it and circumstances. So greetings for whatever time of the day it is in your part of the world. I am Gunjan Veda, Senior Advisor with the Movement for Community-Led Development. And it is my absolute pleasure and honor to welcome you to the Special Sector Dialogue on Community-Led Health Systems. This is the third in the series of sector dialogues that the Movement for Community-Led Development has been organizing. We had the WASH Dialogue in August, and we had the Livelihoods Dialogue earlier this month. Recordings, key takeaways from both the dialogues are available on our website. We are very happy to say that we are organizing today's dialogue in partnership with CanWash, and you will hear both about the movement and CanWash very shortly. But before that, just a few announcements, housekeeping, and I think that can be really short because by now all of us are used to Zoom walls, right? That's our new reality. So we really value your voice. That's what these health sector dialogues are about. Engagement, views, sharing learnings. At the same time, we have a lot of people and you'll see the numbers are going to keep increasing. And so we want to make sure we cut out the noise. So please keep yourselves muted unless you are speaking. But use the chat box. That's your best friend. If you've been on movement calls, you know that we take the chat box very, very seriously. We monitor it all the time. We use it in the key takeaways. We use it in the discussion. So please use the chat box. And right now, if everybody can just introduce themselves in the chat box, that would be great. It's always nice to know who we are sharing mental space with. And in this case, virtual as well. So please do introduce yourselves in the chat box. If you have preferred pronouns, please put them next to your names so that it helps us in the course of this dialogue. Can we go to the next slide, please? So that's what the housekeeping announcements. Why are we doing this? Well, we're doing this because the pandemic has shown us more than ever that communities are the first responders in any crisis. I think at this point, it's going to be very difficult for people to turn around and say, what is this community-led development you're talking about? You know, or community-driven development or locally led development. There is a recognition of the importance of communities, of local organizations. Yet at the same time, there is this, among a lot of technical experts, a feeling that, yes, it's an important idea in principle, but it doesn't really apply in our sector, right? Because our sector is very technical. It's specialized knowledge. You know, it requires expertise that we can't find in communities for some reason. And so the sector dialogues have been designed to look at how the CLD really work in and is important for every sector. Because communities are the key if we really want to attain universal access to health. And so we're going to start with a very quick introduction. Then we are going to go into a panel discussion where we're going to look at decolonizing health and financing community-led health systems, among other things. We have a brilliant lineup of panelists for you. After that, we're going to go into breakout groups. The breakout groups are spaces for us to talk about what are some of the best practices we have seen? What are some of the obstacles? What is it that we can do together to strengthen community health systems? The breakout groups have been created based on thematic areas, and each of you chose the area that you would like to be in. So we're going to have RMN-CHA, we are going to have immunization and vaccination combined with HIV/AIDS, and then we're going to have community health workers. Finally, we're going to come back and all our facilitators are going to share that one thing that stayed with them from the breakout group in 60 seconds. And we'll end with a call to action. So straightforward agenda, but lots of exciting stuff happening. And now, without further ado, I would like to introduce my co-moderator for the event, Jessica Fern. Jessica is the Director of Global Health Impact at CanWash. And Jessica is going to start us off by introducing with a land acknowledgement and telling us a little bit about CanWash. So Jessica, over to you.
Wonderful. Thank you, Gunjan, and welcome everybody. CanWatch, the Canadian Partnership for Women and Children's Health, is so excited to be co-hosting this event together with the Movement for Community-Led Development. As we were talking about before this session began, we are, as organizations, we're both big fans of each other because we share an interest, especially in the next coming years, really looking at how can we work together with the members of our movement and of our network to really push this conversation on community-led development within the health space more fulsomely. So the fact that so many of you are interested in being here today as we have this discussion is really heartwarming, and I know it's only going to be the first of many discussions. As Gunjan mentioned, I want to just quickly speak a little bit to where I find myself today. But first of all, it's so wonderful to get to be in these virtual spaces where we get to connect with colleagues who are in their homes or in their workplaces all over the world. So for me, my home, where I'm coming to you from, is in a city that's widely known as Ottawa, the capital city of the nation of Canada. However, this land is also known as the traditional and unceded territory of the Algonquin First Nations peoples, as well as many other Indigenous nations from across Turtle Island. I identify as a settler to this land, and so I am extremely grateful to the past and present stewards and guardians of this land. And I also want to acknowledge that this is a really important week for us here in Canada. In 2 days' time, on September 30th, we will be having our first ever National Day of Truth and Reconciliation. And this is an opportunity for everyone who lives on this land called Canada to reflect on the past and present impacts and realities of colonialism, and to commit or recommit to meaningful reconciliation efforts. I also want to acknowledge that colonialism is certainly not limited to so-called Canada. I recognize that many of you right now are at home in nations around the world that continue to experience the harms of colonialism present. And so I really hope that you will join me in acknowledging with gratitude the caretakers of whatever lands you find yourself on, and that today's discussion will be an opportunity for us to think about how we can collectively move toward reconciliation and a more just space as well. So thank you for giving me the opportunity to speak to that, and I look forward to continuing to talk with you over the next hour and a half. I believe, Christiane, I'll turn it over to you.
Great, let me just bring up the slides. Welcome everyone, and thank you for coming. The Movement for Community-Led Development was launched in 2015 on the same day as the 2030 Agenda with the development of the Sustainable Development Goals. We are a global consortium of over 1,500 local civil society organizations and 74 INGOs that support practices of community-led development to create and achieve locally owned visions and goals. Through strategic and collective action, Movement for Community-Led Development seeks to ensure that every person has a voice in decisions that affect their lives, to connect individuals with equal and affordable access to public service, and to build a partnership between local civil society organizations and governments. The Hunger Project serves as the global secretariat of the Movement for Community-Led Development. We also have national chapters in 17 countries across Africa, Europe, and the Americas. Before I go into our goals, what is community-led development? Community-led development is a planning and development approach that involves the process of collaborative work to achieve and create locally owned visions and goals. This approach is based on a set of core principles that seek to encourage the leadership of local voices, build on local strengths rather than focus on problems, and set visions and priorities according to the people who live in that geographic community. This diagram outlines the theory of change process, which begins with the formation of two types of partnerships for collective impact: advocacy partnerships and facilitation partnerships. Through advocacy partnerships, civil society can engage national governments to decentralize and devolve public resources to the community level. Through facilitation partnerships, citizens achieve healthy, productive, resilient, and self-reliant communities. When these two streams converge, they develop capacity and commitment to the goals of community-led development. Community-led development programs are facilitated by the work of the movement's national chapters that bring together civil societies and aligned actors to support this theory of change, and global working groups that support these in-country processes by networking, coaching, research, evidence building, and supporting communications. Thank you all for being here today.
Thank you, Christiane. And with that, Jessica, I'm going to turn it over to you.
Wonderful. Thank you, Gunjan. So we've got a lot to cover in a short period of time. So we're going to dive right in to our panel discussion. And we have two really interesting and incredible panelists who will be speaking. What we'll do is we'll hear from each of them in turn, and then we'll have an opportunity to have a discussion with them all together, including some questions that I have and some questions hopefully that you'll have as well. And this will provide a great framing for the breakout discussions that we will then have. I just want to note that, as Gunjan said at the top, the chat is your friend. So as both Angela and Chris are speaking, please feel free to put any questions that come to your mind in the chat, and I'll be combining them and bringing them into our discussion, starting with the questions that we get first. So feel free to put them in there. But to start us off, we're first going to be hearing from Angela Nguku. Angela is the founder and executive director of the White Ribbon Alliance, Kenya, a people-led movement for reproductive, maternal, and newborn health and rights. A passionate maternal, newborn, and adolescent health champion, Angela's career spans over 16 years of dedicated work towards ending preventable maternal and newborn deaths globally and amplifying the voices of marginalized and vulnerable populations in Kenya, throughout Africa, and around the world. Angela serves as a member of the People's Advisory Board of the Lancet Global Health Commission on High Quality Health Systems in the SDG Era, the Civil Society Advisory Group for the Global Action Plan for Healthier Lives and Wellbeing, as well as the Deliver for Good campaign advisory group in Kenya. Angela also serves as the Global Health Council and Merck for Mothers on the Global Health Council and Merck for Mothers Global Board, respectively. Welcome, Angela. We are so pleased to have you with us here today.
Thank you. Thank you so much, Jessica, and thank you for the introduction. I'm so glad to be in this session because I feel like it speaks to the issues that I keep on speaking about each and every day. When I wake up every day, I'm waking up to speak to issues that affect communities. I'm waking up to speak to issues that I know are very close and very dear to me and are very dear to the community that I work with. And the reason is because over my years, over the 17 years now of working, I've worked across different countries, in my country, across Africa, and in Asia and a bit in Latin America. And I realized that at the end of it all, communities are so critical, but yet they are not part and parcel of decision making. I will start by saying that we all know that communities are the most integral part of our society. The communities have always been, they are the users, they are the end user at the end of the day. Whether it's an individual, whether it's a family, they form the community, they form the society where this takes place. But when it comes to decision making, when it comes to the way healthcare is organized, I feel like they are always sitting on the fence. They are always the backbenchers. They are never consulted. Their voices are not on the table. And as such, for me, across board and across the years that I've worked, and where I work now at White Ribbon Alliance, the voices of communities in decision making. There's a saying that I say that if you go to a place and you feel that you are not on the table, don't even think about just pulling a chair. If you feel that the table is not enough for you to be there as a community, just pick the table, dismantle it, and actually tell them to create a bigger table for all of you to sit, and so that you can make decisions. Why am I saying this? Because I am a trained midwife. I'm a graduate midwife. And when I was trained, I was never told that I should give space for the community, for the user to actually make decisions on the kind of care that they are receiving. I've moved to the global health space over my working life. And what I've realized that is the supply side, whether it is the governments, the donors, the decision makers, the policy makers, the programmers, also have an assumption that these real experts of care, who are the communities themselves, should not be on the table. Yet, they are the ones who are going to receive this care. And as such, for me, it is so critical that whatever care that they are going to take part in, that they must shape how it looks like. Is it equitable? Is it quality? Is it of the right? Is it at the right time? And that really has gotten me to really think around decolonizing the way health is organized. Because I feel we are suffering from colonial hangovers of how health has been organized across board. When I say that, I say that from different fronts. One, in my training, when I was being trained, I was trained first and foremost with a thinking that healthcare should only be foreign. Anything that comes from the indigenous traditional is not supposed to be part and parcel of the formal healthcare system. And as such, I was until much later when I thought, but why? Why am I being told that to watch when a baby is turning blue? Yet this baby is so dark when they are born. How will we know that this baby is going to turn blue? Then it got me thinking, at the end of the day, that is actually from our Western side. It is not the way where my community, and my community will not perceive that. And as such, that even the thinking around education and all that needs to change. So I wondered, every time I go to a health facility, for example, I find, for example, antenatal mothers, I'm a graduate midwife, so I was dealing with mothers most of the time, but they are quiet. They come from communities, they have different values and they like. They come to the health facility, they are told you must come in the morning, because from the colonial days, healthcare was supposed to be, you go to the facility, everything has to happen in the morning with MNCH, ANC, everything happens in the morning. But we also understand we are coming from communities that most of them are actually informal, they have informal jobs and the like. They will go to their farms, they will go for their small businesses, they'll go fetch water, they'll go get their firewood. And as such, the healthcare system, the way it's organized, should be able to be opened. The health clinics, health facilities must be opened when it is necessary for these communities to, when it is the right time for the communities to be there. And so I have kept on questioning, why is it that our healthcare facilities are organized to be opened only in the morning when communities are supposed to be in the farms, fetching water, doing all that? Why have we not ever thought, let's talk to what communities need, so that the healthcare is organized around the needs of the community, but not around the needs of the healthcare system? Further than that, we know that for the longest time, primary healthcare, which is driven by communities, prevention, promotion of healthcare, should be the most integral part, should be the most critical aspect, and that is where the community is. And it's actually driven by communities, and there's no better era to talk about that than the COVID era. And so we have seen that one of the key things that COVID has really taught us is that, are we really involved? Are we being part and parcel? Because I'm speaking from my own experience in my country, where I saw government using police to run after communities. People, you need to wear masks. You need to wash your hands. You need to do this. You need to do this. If only this had already been part and parcel of the way healthcare is organized, we will not be thinking of running after people to actually tell them to do what is right. What does then that leave us with? It is the high time, whether we are the suppliers of the healthcare, whether we are the funders of the healthcare, whether we are the policy makers of the healthcare, whether we are whether we are at the global space, at the regional space, at the country space, we rethink how we have really taken healthcare and how healthcare has been organized, how it is delivered, how it is funded, and how it is actually been running across board. And one of the things that I've learned, and I'm talking this from a survey that we undertook as White Ribbon Alliance that was called the What Women Want campaign. This campaign sought to understand what quality of care means to women and girls. And it came from the premise that in 2018, a study was done and the results were launched. So it's called the Confidential Inquiry into Maternal Deaths in Kenya. And what was established is that poor quality of care was the leading driver of maternal deaths in my country. And as such, as White Ribbon Alliance, in conjunction with the broader White Ribbon Alliance movement, we sought to understand, what does quality of care mean? Because even the Lancet report came up and said quality of care is actually one of the poor quality of care is one of the reasons why we are having the poor health outcomes and the like. And so we sought to understand, what is the say of the experts, that is the community, the mother, the girl who is supposed to be using this care? What is their definition of healthcare? And when we went, we were really shocked. We listened to women across board, 1.2 million across the world, and 120,000 from my country, Kenya. And what women and girls told us quality of care means to them actually now brought us to a broader realization. And it has given me more more energy to really push for community-driven healthcare, where decision-making does not come from the supplier of the care, but for the user of care to define what is it, what does that mean? The campaign or the survey came up with some very critical aspects. Water, sanitation, and hygiene topped in my country as the topmost definition of care. Yet, when we go to health, when we go to donors, when we go to the government, when we go to different players, they tell us that actually women and girls need facilities, more facilities. Yet women and girls told us they want clean linen, clean toilets, clean sinks, clean floors, and the like. Women and girls told us that they want respect, call us by name, organize the facilities when we can be able to come there. Give us the food that is culturally acceptable. Give us some warm tea when we come. Simple things which do not require rocket science, and so many other things. And so that really got to speak to the aspects that we're talking about today. Can we really look at critically at who has actually been driving? What are the historical injustices that have actually made healthcare to be shaped in a way that does not really bring community at the center of it? I am really a propagator of primary healthcare because I believe primary healthcare is community at the center of it all. And so for me, the thing that makes me wonder and makes me wake up every day is to go and preach the gospel of community at the center of development. Decolonize the way healthcare has been done previously. Let us come together and ask ourselves, why have we missed the point? Because why are we not driving down the maternal health outcomes? Why are we not driving down? Why are we not reaching maximum integration? Why are we still seeing people dying despite all the investments? Because we are not doing it right. We have let off the most critical agency, the most critical expert, the community, who is a user and the end user of the product. Thank you so much. Let me stop there, wait for your questions, Jessica. Thank you.
Oh, how wonderful. Thank you so much for those remarks, Angela, and I can't wait to dive back into them in just a second. But before we do, we're also going to hear from another one of our colleagues, Chris Collins. And let me tell you just a little bit about Chris. Chris joined the Friends of the Global Health Fund in 2016 and serves as its president and CEO. He leads the organization's efforts to engage U.S. decision makers on the life-saving work of the Global Fund to fight AIDS, tuberculosis, and malaria, and the importance of expanding global health investment to bring these epidemics to an end and advance global health equity. Previously, as the chief of the Community Mobilization Division at UNAIDS, Chris helped make the case for the investment in civil society as an essential part of the AIDS response. As Vice President and Director of Public Policy at AMFAR, Chris defended global AIDS research and program funding and worked to advance domestic HIV policy and global key populations programming. Welcome, Chris. We're so happy to have you with us today.
Thank you. It's wonderful to be here. Thanks for including me. And Angela, that was a wonderful statement. It's hard to follow that. I will just comment, make a few comments from, where I'm coming from, which is right now, I'm working in Washington, D.C., trying to make the U.S. system work to support more funding for global health in general, the Global Fund, but also health in general. And I think we are at this moment that could be a change moment in global health, which could include more of an awareness about the need to invest in strong systems for people, in addition to making real progress on specific disease challenges. And, it's a time when we could begin to reshape some of the ways that we've been approaching global health for a long time, getting more systems oriented, acknowledging and funding the roles of community in healthcare provision. The cards have sort of been thrown up in the air in global health. And every day I'm thinking about what can we all do together to create a global health architecture and response and funding system that meets people's needs, that, for example, thinks of readiness for the next pandemic in terms of building strong health systems that rely on communities for results. Those are the kinds of things that I think we're grappling with, at least in the Washington side right now. My context is I come out of the HIV movement. This is very personal work for me. And if you worked in HIV, that it's all about the community, right? It's all about the community in multiple different roles, as advocates, as being at the table, as research is designed, to planning healthcare delivery, to advocacy for resources, to defending human rights and the needs of key populations and marginalized populations, to playing a major role in delivery of services, and then also to monitoring services that people are getting or not getting. So, I think it's clear to everybody here that the community is the game changer at every single level of the health food chain, from R&D to figuring out whether delivery worked. And I think we just need to do more to make that visible, to make that concrete, to document it, and to demand adequate support for communities in all those roles. I think, from our context here, one of the challenges / opportunities of the future is, a lot of policymakers are taken with the idea of pandemic preparedness. We just had a global summit that President Biden convened, in part to get people to do better in terms of responding to global COVID, but also to lay the groundwork for new financing for pandemic preparedness and response. Yeah, it's a real opportunity to ask, what does that look like? Does that include communities in the governance of how the new pandemic preparedness and response, I'll say PPR, if that's all right with you, that new PPR system, where is it? And is community and people affected by diseases represented at the table? Is that entity able to fund community-based organizations? In the United States, we have a history of investing big in vertically oriented programs, particularly PEPFAR, the Global AIDS Program for the United States, and the President's Malaria Initiative. What's the role of vertical programs? How can they change so that they are more inclusive of community and more focused on building out to deliver health services, strengthen health systems, move us down the road towards universal health coverage, move us towards better pandemic preparedness, and how those things are closely interlinked, without losing the focus on getting real concrete and dramatic results in those focus areas of the vertical programs. It's a real challenge. I don't have the magic answer to it, but I think it's one of the things we have in front of us as a challenge and an opportunity. Earlier in the year, I talked to folks in 6 different countries around the world about how the HIV response, what role it was playing in COVID and what role it was playing more broadly in health systems. And it was fascinating to hear, different in every country, of course, but in every country, turns out that the HIV platform wound up being really central in terms of the COVID response, really important. And in particular, it was important on the community side. Those community networks and services and organizations that had been supported through the HIV response were able to meet the challenge of COVID and reach a community with information, with PPE, help people get into care. They mobilized right alongside everybody else on COVID responses. And, that's particularly true in the area of key and marginalized populations and COVID, that it was governments very often relied on HIV community networks to reach those harder to reach folks, because they'd established those relationships. There was a person in Vietnam, a community person, who said to me, the community has been central in terms of what we've done on COVID here. And it's no surprise that that's true, because we've had the investment in community. We've had community taken seriously much of the time. We've had the training and the ability to work together. So there are these vibrant networks of community in countries all over the world, engaged in healthcare, able to do one thing they were hired for, but also able to adapt quickly and provide other services. We need to be recognizing that. We need to be telling that story to policymakers, and we need to secure the funding and the adequate support for those organizations. You know that the community side of health care has always been underfinanced. It's one of the oldest stories in the world. And, you know, so I think one thing on the financing side, just as an advocate working in DC, is we need to be getting global health funding into programs that are going to recognize and rely on communities and support them. I would include the Global Fund in that. But we also need to be thinking about where do we need to set up new funding arrangements so we can get funding directly to community groups. And I'll say more about that in a minute. You've probably heard of an ERASA survey from, I believe it was earlier in the year, a survey of state funding for community-led advocacy in Southern and Eastern Africa, and it conducted with several organizations. Nearly half the respondents reported a decrease in funding over the past 3 to 5 years in general. And some of the factors in that were difficulties in obtaining core funding support, short-term nature of grants and funding opportunities, making it difficult to sustain progress, barriers related to bureaucracy and excessive complexity in terms of reporting, and major concerns about the disruptive impact of COVID-19 on social enablers and future funding for such work. So, you know, this is one thing, when I was at UNAIDS, my job really was about, raising the importance of community work on all these different levels. There just really wasn't even the data there in terms of what kind of funding is available for communities and what the policy issues were. So that's been, I was happy to see this survey, but that's one part of this, is just to be talking about the centrality of community and how community really rose to the challenge in COVID, but also document the underfinancing of those responses. My central focus is on, in my job, is on, so getting support to the Global Fund. And I do think no organization is perfect, but I think there's a lot of ways in which the Global Fund presents a model that we can build on. It involves community at multiple different levels. Again, I'm not going to say everything works perfectly, but community is represented on the board of directors for the Global Fund. Community is supposed to be on the country coordinating mechanisms in each country, and community should be contracted with for service delivery through Global Fund, and that is doable. So that's one example of a model I think to work with as we're thinking about new architecture in global health. What does pandemic preparedness and response look like? It's models like the Global Fund and improving on those models that I think we can talk about. So, I think a big part of it is then also just the advocacy, and maybe we can get donors to join us in advocacy with national governments to understand the contribution of community. But then also there are technical issues, I think, that need to be worked out in terms of helping countries set up a legal structure and a regulatory structure that allows more social contracting, more direct financing from the national government to communities. In so many countries, that just isn't the tradition. And it's not something that's supported. So we need to act politically on that, but also need to help with the regulatory and legal logistics of that. I do think there's opportunities for some donors, and I think the United States is one example of that, to provide some incentives to grantees around greater inclusion of community and service provision, and we can talk about that. Thinking about what other dedicated organizations there are in terms of financing community, there's certainly, like in the area of HIV, the Robert Carr Civil Society Network Fund, which gives direct grants to consortia of regional organizations. That's a very important model. That needs more investment. I'm involved with a group trying to build a network of national health advocacy, a national health advocacy funding system that we're working on with advocates around the world, trying to do that. So I just think right at this potential change moment, we need to be thinking about what are those pieces that need to be in place policies within the big organizations like Global Fund, PEPFAR, et cetera, how do those need to change and do better? But also, how do we get direct funding to communities through other systems? And, again, I think there's a lot of work to do in terms of telling the story, of documenting the impact and essential nature of community services. That's going to help us make the case with UHC and pandemic preparedness funding. One interesting thing that we're up against is the JEEs, the system that had been used to, or one of the systems that had been used to assess readiness of countries to meet the next pandemic challenge. Community is almost invisible in those guideposts in the JEE system. And that tells you a lot about the undervaluing of community. And it shows you how things need to change and how those kind of global metric systems that we have around health system strength and readiness have got to capture community. If they don't, that makes it all the harder to raise the funding we need. Lastly, I would just say that I think in addition to having, because of COVID and the UHC movement, all these opportunities, the potential for a real change moment here in terms of global health financing and also architecture. From the other side, there's also the change moment is being enabled because there's new opportunities in use of data and IT to help community be more engaged in monitoring and reporting on quality of services and availability of services. So I think data and IT is a major area where we could really help grow in a very documentable way community involvement in health. And I also think some of those data and IT pieces can help personalize healthcare in a way that community can really support. Lastly, I would be remiss and not be doing my job if I didn't say that the overlay for me is, I think we're at a time of really incredible opportunity here. But I also worry because I think so far in COVID, we've seen the world not step up adequately. We've seen a lot of talk about the need to invest in pandemic preparedness and invest in getting vaccines and other commodities out related to COVID. We haven't seen the money nearly as much as we needed to. We haven't seen the commitment level that we're going to need. All of us need to work together to advance community role in health, but also just to mobilize rich countries to realize that it's in their own self-interest and it's a moral imperative to greatly increase investment in global health in a way that's responsive to communities and based on human rights-based programming. Again, I don't have the magic answer about how to do that, but I think we all need to be thinking about that big picture too, of mobilizing governments and realizing we can't just have status quo. And I think it's in the next year that we have the opportunities to make a lot of those points.
Wonderful. Thank you so much, Chris. A lot of thoughts there. And I can see from the chat as well that this is really touching on something that that folks want to discuss more on. And I think that this is going to be great. I think for all of our breakout rooms, which we'll talk about momentarily, this question of financing is one that we really need to bring in because there's a lot to unpack there. To make sure that we have time for that, I'll try to keep it just to one question. So my apologies to those that are in the chat, but we'll bring that into the small discussion. Angela, when you were speaking earlier, you talked about that it's not enough just to invite people, invite communities to the table. We actually need to talk about dismantling and building an entirely new table. And you gave some fantastic specific examples about how healthcare is organized in communities. And then also, Chris, when you were just speaking there, you talked a lot about telling the story, especially towards the end about, how we tell the story to, engage decision makers. So my question to you both is about decision makers. How, if at all, do we engage those that are currently in decision-making roles, currently in positions of power, whether that be our governments, whether that be funders, what ideas or suggestions do you have for how we can work with these decision makers to actually do some of the dismantling that Angela talked about, and building of a new table together with communities? Have you seen anything work, anything that we should be kind of reflecting on as we go into our discussion? Maybe Angela, did you want to start us off with anything?
Yes. Thank you so much, Jessica. And again, thank you, Chris, for those amazing tips that you've given us. I think one of the things I say all the time is that numbers don't lie. In the same thing that experiences, people's lived experiences and realities don't lie. And so for the longest time in my working time and in different spaces, in the things I read about documents and all that, I realized that there's always a focus towards only looking at things from only the quantitative aspect of it. Yes, we know quantitative data is so critical in shaping how decisions are made. But I think behind all these numbers are narrative stories, are people's lived experiences, are people's realities of what is it that is really going on in their lives and the like, are people's moments to share what have I really gotten? What is it that, yes, I have gone to those health facilities, I have taken these drugs, I've done everything, but this is it. This is a repercussion. This is what I can. People are yearning to speak up, to give feedback, to make things better. But over and over again, whether it is at the global space decision makers, at the regional decision makers, whether at the national, even subnational, even at the health facilities, the voice of this critical player who has the story, the lived realities of this, what they are going through, is never factored in anywhere. And so for me, the whole aspect of not stopping, I think decision makers need to stop looking at things from one side and look at things holistically, multisectorally, because I keep on saying health is multisectoral. Health cannot only be looked at from one angle, because health is affected by many things, whether it is infrastructure, how will people access that health facility? Whether it is nutrition, are people getting the right nutrients? Are they getting the right, are they having enough to eat? And are those, is it balanced, all that? It is affected by security. You might have the most beautiful health facilities in different spaces, but because of insecurity, no one gets to go there. But until you listen to the stories of what is happening around that, you as a decision maker, you'll sit on your ivory tower somewhere, sit on your boardroom and assume, I have done this. But until there's investment to really understand what are the realities, what are people going through? During rain seasons, I've seen women not able to access health facilities. People have gone to health facilities, but they cannot be able to because health workers are few, or even they are not treated with care when they get there, and then they stop going there. So I think the decision makers need to be all-rounded, ensuring that at the end of the day, they have every player, the user, the supplier of that on the table to discuss what is it like, what is really coming out, what is stemming out of that, what we are giving. Because for the longest time, we have kept on doing things over and over the same way and expecting that they are going to change. But we are not changing our way of doing things. We are only looking at health from a supply side, plus from a supply lens. The other thing that we ought to do, and I like what Chris said, is ensure that we know that for the longest time, communities know how to take care of themselves, self-organize, self-advocate. And we have experiences and examples of beautiful places where communities have done things. I'll talk briefly about a program that we have not finished doing. It's called UHT for Me. When we did this, we did the survey that I talked about, the What Women Want campaign. We realized that for the longest time, women and girls living disability have never been a factor in maternal health. So it is assumed that these people have no feelings, so their sexual reproductive health needs should not be taken care of. Two, when they go for family planning, all they get is, you are not supposed. It's like, oh, you are defective, so you should not be thinking, so you should not have feelings and the like. More to that, when they go to deliver, and I'll talk from my own experience as a midwife, I was not trained that if a woman comes and she's on a wheelchair, she's on crutches, she ought to have a special bed, a special toilet. So I expect that woman to jump, to climb on that. So we have made everything look equitable, but there are so many inequalities. And so we worked with communities and governments in 2 counties in my country to make them realize that there is a group of women and girls who do not really enjoy their reproductive health services because they lack this. And I can proudly say that up to now, I've seen policies change in those counties to really speak, to ensure that the needs of these women and girls living with disability are taken into account, because we have organized them to come and speak up. We have seen hospitals now reconstruct ramps for women and girls using either crutches or wheelbarrows to actually, not wheelbarrows, but wheelchairs to actually get into the facilities. I have seen health decision makers listening to these communities and hiring people to train them, health workers, on the sign language and the like. So there's a narrative that needs to change. And I realize that when there are resources for communities to be able to self-advocate from their whole lived realities and narratives, then decision makers get to listen. So I think I'll end it there. I'll say that it's possible, it's doable. We just need to focus to make sure that we are aware that there's a problem somewhere and that needs to be solved. Yeah.
Thank you, Angela. And I think, I know we'll go into our breakout rooms momentarily, but I think you just kind of referenced this idea of, what's required is resources. So Chris, I want to give you a chance to answer the original question that I posed, but I think, we've talked about this before, right? Is how did the funds actually get to community-led organizations? Part of the existing mechanisms are often, requiring this kind of flow-through effect and make it very difficult for community-led organizations to directly receive funding from major donors. Do you have any thoughts or reflections on kind of what dismantling that process might look like, or things that we should be reflecting on?
I think sometimes when you're working with policymakers, the thing to think about first is how do I provide them with a solution to a problem that they have, versus making a big ask of them. You're actually doing a big ask of them when you provide the solution, but you couch it as a solution. In other words, you want to be funding healthcare services that consistently show results for people, that have a number, that have quantifiable, measurable success factors. This is absolutely true in kind of the secret of how, it's not a secret of how U.S. support for PEPFAR, President's Malaria Initiative, why have those been maintained year in and year out? It's because those programs tell policymakers what they're delivering to them in terms of lives saved and bending the curve of incidence. And I think we can get better at documenting and showing how you don't, as a policymaker, get the results you want without community. And here's examples of why that is. Specifically, I think the tragedy of COVID presents us with enormous opportunities to do this, to tell the story of how communities were indispensable in COVID responses, and what that meant, and what it would have meant in the absence of those responses. And we've seen some documentation of that. I mean, Malaria No More had a really interesting report that came out in March, I think, of this year, Malaria No More at the UK office. I mean, they were basically talking about how pandemic preparedness in many places was done on the back of I shouldn't say on the back, was done with the involvement of community workers who'd been working on malaria. And so, I mean, I think better capturing the data, better telling the story about how the successes in health wouldn't have happened without community, and then being very clear about how that funding needs to work. I mean, I think policymakers, at least in my country, can get concerned when they feel like they're being asked to open up lines of funding without knowing what that's going to produce. And so I think we need to be showing the ways in which funding gets to community that has been most successful, and it has made the whole health system work for people. And I mean, for me, we need to just, we are demanding it. We need to demand that. But I also think we need to ask our questions about how to document what we do and communicate that in a much clearer way. I mean, just to say, I mean, you've got, in the United States, you've got PEPFAR, believe me, going to Congress every year with a nice slick report saying, this is how many lives we saved this year. This is how many kids didn't acquire HIV at birth because of PMTCT services we provided. That kind of data is incredibly powerful. on the policy level and on the finance level. And I think we need to think about how to move in that direction. That is not in any way to take away, and I think a lot of what happens in communities, it is about community autonomy. It is about not having big strictures about how you act, because you need to be able to reach marginalized folks that need additional attention to access services. It's a lot of work. It takes concentrated work. And you need freedom at the community level to be agile, to meet people where they are. So it is harder than counting widgets or saying I handed out X number of bed nets. It's harder. I get it on the to document what community does. But that said, I think we need to get better at it.
Well, thank you both. There's so much to unpack there in our upcoming discussions. So Gunjan, I believe you're going to come on now and tell us a little bit about what we can expect in our breakout room discussions and where we can take the conversations from here.
Yeah, thank you so much, Jessica. And yeah, that was such a fascinating discussion. And I see a lot of great comments in the chat box, which we are tracking. And the questions and the comments, we will continue to track them. For now, we're going to move into breakout groups. All of you selected the groups that you would be, you wanted to be in. Christian, can we have the slide up, please? Thank you. So we're going to do 5 breakout groups. We have wonderful facilitators with us. We have Taria Adams from the White Ribbon Alliance, Nigeria, Vashti Rabong from Youth Coalition for Sexual and Reproductive Rights, Kiki Kalston from the Global Health Council, Dr. Stella Kanyere from Living Goods, and Jessica will also be facilitating a breakout group for us. We will have about 25 minutes, and the objective of these breakout groups is to now begin to unpack some of the discussion we heard here, to look at our own work in these specific areas. Of course, recognizing that, as Angela said, health is multi-sectoral, and there is a danger in the vertical silos that we built, but we did want to look at some examples, some obstacles, and the way forward. So that's what's going to happen in your breakout groups. You are going to see a window pop up very shortly, which will invite you to join a breakout group on the topic that you selected. Please select that. We'll have 25 minutes. We'll come back in 25 minutes, and then hopefully we'll have time for a report back where each of the facilitators will give us one key takeaway. And if not, we will go directly to the call to action. So Sarah, are the breakout groups ready to launch?
Yes, they're ready.
Perfect. So you will all see a note coming up on your screen inviting you to join the breakout groups. Please join. So I know we have about 8 minutes. We have a call to action and a couple of things, but I still want to see if we can have each of our facilitators come in for maybe 30 seconds, but share that one key takeaway that stuck to you from your breakout room. And I am not going to follow any particular order at this point. So maybe we can start with Jessica. Sorry, I'm going to put you on the spot first.
Oh gosh. Well, we were right in the middle. I think like many people were right in the middle of making a point at the end. So we went right to the end of time. Lots of great points. I think a lot of our discussion resonated around, just critically looking at the existing models. Angela kind of referred to it at the beginning. We've glorified certain models, particularly within healthcare, and we've come to really privilege, what we call scientific rigor approaches to data. But as a community-led development process, we need to challenge that a little bit. We need to think about qualitative data and how to integrate that more, and we really need to be thinking about community resourcing, because when we see what happens and what significant negative impacts there are when community health services are not adequately resourced, it leads to very real loss of life, and we need to make sure that those investments are there and to kind of challenge the traditional approaches that we've set up. It was a great discussion.
Thank you, Jessica. Kiki?
Thanks so much. We had a great discussion and a lot of reflections in our small group around community health workers and the role that they play in their communities. I think the main takeaway for us and the main kind of looking forward best practice, what we need to do is the pandemic has shown us in so many ways how important community health workers are in their communities and as critical resources for their communities for, individual, family, community health. And they are important leaders in their communities, and we need to value and compensate them and make sure they're recognized as the community leaders that they are. So I'm just going to leave it at that.
Thank you so much, Kiki, and thank you for sticking to the time. Stella. Stella, are you here?
Yes, can you hear me? Kiki's group, I think, was aligned with our group that was discussing community health workers. And what stood out for us is that number one is that they need to be recognized as part of the larger healthcare system and, get that thumbs up and recognition that they deserve for the work that they are doing. But also quickly, the group flagged that, they need to be compensated. They do a lot of work, but there's a lot of, we look at it as voluntarism, and yet they're putting in a lot of time. So there was, a discussion around them being compensated, but also them being adequately trained so that they're able to give quality services to their communities. Then we had discussions around, them tapping into digital tools. We know most of them are still using paper-based data collection tools, and some of this data doesn't get into the national system where decisions are being made. So we had discussions around that. And then there was something around supervision. They need to be adequately supervised by, healthcare workers from the mainstream. But the biggest one is that they need to be recognized, compensated, and trained. Thank you.
Thank you, Stella. Washti.
Thanks, Gunjan. I think for our group, it's, cutting across from everyone who has been sharing. So first, I think one of the great things that was raised was how we in our work has to be very critical in the positions that we take in doing the development work or the community-led development work that we're doing, because sometimes it's hard to navigate something that we struggle. And also there was a mention of how co-ownership of or ownership of communities in leading development has been helpful, has been successful in ensuring, say, for example, access to vaccinations, and making sure that, and even though that, and with this kind of development, it seems that it comes very organic to the community, that, we do this, there's like a cross-movement advocacy work that has been doing organically, and also to include the discussion on volunteer folks volunteering. So how do we also how do we ensure that they are also mindful on the work that we're doing? Are they, when do we step back on the work that we do, just to ensure that this is community-led? And I think there's a struggle of envisioning, imagining how does like dismantling the top to bottom or top down approach in development looks like, right? And it would be a great opportunity if we have different models coming from different communities to show this.
Thanks so much, Vashti. I know that our group had connectivity issues, but I believe Taria is back. So Taria, if you're back, then in 30 seconds, your one quick takeaway, and then we are going to move over to Angela. Taria, are you back? Sorry, I think we've been having connectivity issues, but a lot of the common themes there, so I'm not going to spend a lot of time on it, just to say, for me, the two things that really stuck out.
Yes, I am back. Thank you so.
Okay, Taria, go ahead, please.
Okay, for me, the two things, a few of the things that really came out was one, understanding the power dynamics in the communities and ensuring that we work around the power dynamic. dynamics. And two is ensuring that communities are part of the design to the implementation phase, and not just, coming to the kind of strongly about and understanding power dynamics in communities. Thank you.
Thank you so much. Thank you to all the facilitators. And now, as we are almost at the end of time, I'm going to hand it back to Angela to issue our call to action. If you can, please do stay a couple of minutes after time, because we have a couple of important announcements to make as well. But Angela, over to you.
Thank you so much. And what a brilliant discussion to really listen to. And I'm so glad this is coming from across the world. It's not just in one specific place. And I think for me, what my take home and what I really would want all of us to really go with in mind is that we all know we are people, and we know that people are born with power, and that automatically means that communities have power. It is the society and the system that really perpetually and slowly takes away this power from communities by assuming that they do not exist. And where they exist, they do not have what it takes to really organize themselves, to really take care of themselves, to really be part and parcel of the system. And this leaves communities disillusioned, apathetic, and almost helpless. And it's no wonder that in some places you hear community members coming up to say, can the government do this? Yet communities have what it takes to be able to do that. And so communities have systems to self-organize, self-advocate, and self-care as a whole, as an element. It is not about other people coming to organize them. They know how to do that. They have done it over and over again. Communities' needs are not homogeneous. Communities have different needs, and their needs are specific to their different contexts and the like. Communities, therefore, have a stake in decision-making because they have the realities, they have the knowledge, they have the skills to know how to take it forward. And so going forward for me, community-led initiatives must and should be recognized, supported, funded, and be integrated in the main health system for us really to change. And if we are going to achieve anything in the sustainable development era, you and me, decision makers, governments, funders, researchers, academia, and all that, have to appreciate and acknowledge that we need to work with and for communities, not for communities, with communities, for them and for communities to transform what is already in them, to really bring back that power. And I think that way, you and me and communities are going to ensure that health and healthcare in general really works and really is shaped with that in mind, and is going to transform and become what we all look out for. I think for me is that we all have a role to play, and we need and must appreciate that communities are key and central to all that we are doing. Thank you so much for having me, and I'm really glad to have been part of this conversation.
Thank you so much, Angela. That was a very powerful call to action. We have a couple of very quick announcements, which I know seems like coming down after Angela's powerful words and all the great discussions, but I promise you they are important, and we'll keep them very short and quick. So Christiane, if you can get the slide up. Thank you everyone for being a part of this. In the movement, we have been continuing these conversations, and we want to continue to have these conversations with different sector dialogues. Tomorrow, we have the monthly call of the movement, where we are actually looking at working with governments and engaging with governments. Do join us if you are able to. It's at 8 a.m. EDT. On Thursday, we have our next sector dialogue, which is on access to justice. We have David Jacobstein from USAID moderating it. And we have an excellent panel, and again, a group of participants from around the world who really have been committed to ensuring access to justice for communities, looking at, community lawyering, looking at community justice systems, social accountability, and others. And on October 6th, we have the big event, Local Means Local: Impact of Community Leadership and Facilitation and Food Security. This is the launch of phase 2 of the movement's research. And we have actually done a rapid realist review to look at how community leadership and facilitation improve resilience, improve equity, and improve food security. We have Don Steinberg, who is the expert advisor to Administrator Samantha Power at USAID on localization, delivering the keynote address. We will have Susan Wong from the World Bank, who heads the community-driven development work, responding to the research findings. It promises to be a very exciting event. I hope we see a lot of you there. Finally, If you are not on the movement's mailing list, please subscribe to it. If you want to know more about the movement, about the events we do, please do write into us. Though everything that happened today, the rich discussion, the points we heard, what happened in your breakout groups, they have all been recorded, and we're going to get 2 products out of this. One, we are going to share, of course, the recordings and the key takeaway summary with all participants. They'll also go up on the website. We are also going to be doing a position paper on strengthening community health systems. This position paper will be circulated, we're co-writing it with CanWash. It will be circulated to all facilitators, to all panelists for that feedback. If you would specifically want to contribute to the position paper, would like to be involved in writing about it, please write to us. I am going to, in the chat box, put in the email ID for all of us. But this is a joint effort. It is a community effort. This is our community. So please do join in and let us know if you are able to, and we can all play a part in ensuring that, we strengthen community health systems. Thank you all so much for being here, for bringing your ideas, your experience, your voice to us today. Thank you to the facilitators, the panelists, to CanWatch and Jessica, our co-organizers and co-hosts for this. My colleague, Sarah Bulbul, who despite a power outage has been trying with her hotspot to ensure that everything went smoothly at this event. Christian Corres, our intern, who helped in putting this event together, and everyone else from the MCLD and CanWatch teams. Thank you so much for being here.
Thank you.
In the movement fashion, if we want, we can all just unmute and say bye, and then we'll disconnect the call. So everyone's voice gets heard.
Bye.
Bye, everyone.
Thank you very much.
Thank you so much, Gunjan.
Bye.
Thank you.
For now.
For
Bye.
joining.
Bye. Bye. Yeah, Gunjan, bye. How are you?
Very well. Thank you for joining, Jude.
Yeah, great to see you.